Bismillahirrahmanirrahim. Langerhan still histiocytosis. The definition: pulmonary Langerhans cell histiocytosis (LCH), previously termed previously termed pulmonary histiocytosis X or pulmonary eosinophilic granuloma. It is a rare condition characterized by infiltration of the lung with histiocytes, which are Langerhans cells. Pulmonary LCH overlaps with a number of other conditions with similar prolonged or similar pathological findings but diverse clinical features. This ranges from localized infiltration of a single organ, as for example eosinophilic granuloma of bone, to systemic diseases affecting multiple organs, such as letter C disease, which is a multiple or a multi-organ disease affecting infants and elderly, associated with poorer prognosis, and also Hand-Schüller-Christian syndrome or Hand-Schüller-Christian syndrome. Although the isolated pulmonary from most commonly presents to chest physicians, pulmonary manifestations also commonly occur in the systemic form of the disease. The epidemiology: it is a rare condition, tends to affect young adults aged 20 to 40 years. The vast majority of cases occur in current smokers, usually heavy smokers, tobacco and cannabis, and may be more common in men who tend to present at a younger age than women. The pathogenesis: Langerhans cells are involved in antigen presentation and are characterized by the presence of well-demarcated cytoplasmic organelles called Bayer-Beck granules on electron microscopy, and the Langerhans cells seen in Langerhans cell histiocytosis appears to be monoclonal, although it is unclear if this represents a true neoplastic process. The antigen stimulus for activating Langerhans cells in the lung is unknown, although cigarette smoke is a possible candidate. And Langerhans cells are typically organized into granulomata that are located in bronchial walls and subsequently enlarge and invade adjacent structures. This results in the radiological appearance of nodules that at first cavitate and then become cystic. Clinical features: typically exertional breathlessness and cough, sometimes with systemic symptoms, as for example fever, weight loss. Pneumothorax occurs in at least 10% of patients and may be the presenting feature. Rib lesions may also give rise to chest pain, and around 25% of patients are asymptomatic, and examination is usually normal. The investigations: chest X-ray, typically diffuse reticulonodular shadowing, sometimes with cystic changes, upper and middle lobe predominance, but chest X-ray may be normal. High resolution CT, HRCT, there is diffuse centrilobular nodules, sometimes with cavitation, and the thin and the thick walled cystic lesions, reflecting lesions of varying age, sometimes bizarrely shaped. These are interspersed with normal lung, upper and middle lobe predominance, and the costophrenic angles are typically spared. Purely nodular or purely cystic appearances may occur. Unusual manifestations, such as single nodules or large airway involvement, are also described. The pulmonary function tests are variable, ranging from normal to obstructive, restrictive, or mixed pattern. There is reduced gas transfer and the exertional hypoxia are common. The transbronchial biopsy may yield diagnostic material, although it is often unhelpful, and risk of pneumothorax is unknown, although may be increased. Surgical lung biopsy is often preferable. The bronchoalveolar lavage, the BAL, increased there is increased total cell counts and the high levels of CD1A positive dendritic cells and pigmented macrophages, reflecting simply the presence of cigarette smoking, use of antibodies, as for example OKT6 to detect Langerhan cells in the bowel fluid is limited by poor sensitivity. Extrathoracic biopsy of involved sites, such as bone, may be diagnostic. The diagnosis usually based on the combination of clinical and HRCT finding. Typically, a young adult smoker with cystis and nodules on HRCT confirmation by surgical lung biopsy may be considered in atypical presentations, such as the finding of solely nodular or cystic disease on HRCT. The appearance of purely cystic disease on HRCT may be confused with emphysema, where cystis lack walls, or LAM, lymphangiomatosis, LAM, which stands for lymphangiomatosis, where cystis are present uniformly in all regions of the lung, including the costophrenic angles. Associations: severe pulmonary hypertension may be seen in the absence of significant parenchymal lung involvement. Direct disease involvement of pulmonary vessels has been described. Manifestations of systemic Langerhan cell histiocytosis, particularly diabetes insipidus, from, from pituitary disease, skin involvement, lytic bony lesions, and rarely cardiac or GI disease. Lymphoma may precede, complicate, or coexist with pulmonary Langerhans cell histiocytosis, and lung cancer, more common, probably as a result of cigarette smoking. The management of Langerhans cell histiocytosis (LCH) include the following. The treatment other than smoking cessation is often not required and may be entirely successful with resolution of radiographic abnormalities. Oral corticosteroids may be tried in symptomatic disease, although there is little evidence to support their use. They are usually they, they are usually administered for at least 6 months. Lung transplantation should be considered in patients with severe respiratory failure or pulmonary hypertension, and pulmonary Langerhans cell histiocytosis may recur in transplanted lungs. Experimental treatments such as the use of interleukin 2 and anti TNF alpha may be of benefit in the systemic forms of Langerhans cell histiocytosis seen in children. Last is the prognosis. The prognosis of LCH is variable. Spontaneous involvement is common, although later reactivation of disease may occur. A minority of patients deteriorate rapidly with respiratory failure and death within months. Overall life expectancy is reduced with median survival 12 years from the diagnosis. Death is most commonly due to respiratory failure. Poor prognostic factors include reduced FEV1 and increased residual volume and reduced gas transfer.